Hi, this is Tom Mauger presenting a case of OCT-assisted DSAEK and cataract surgery with lens implant in an eye with a previous PK that had failed. The original PK was done for keratoconus. There is a significant amount of corneal edema and also subepithelial fibrosis that I thought might be a problem. I like to do a temporal incision that's multi-planed. I use viscoelastic of hyaluronate in these cases. Use my standard 2.4 millimeter keratome. At this point, it was found that the view-in was not adequate to perform a competent capsulorhexis. Therefore, I went ahead and removed the subepithelial fibrosis, much in a manner that you might remove a Salzmann's nodule by peeling it off. After a little bit of work, it eventually peeled off nicely. Sometimes I'll do this at the end of surgery if I feel like I can do the surgery adequately through the cornea, but feel that it might be visually significant for the patient. In this case, it was both visually significant for the patient as well as for the surgeon. Here it is after it was removed. View-in was much clearer, as you can see, and the capsulorhexis and cataract surgery could be performed. Cataract's been removed and the lens implant is inserted. I use my standard one-piece posterior chamber implant. Donor graft is transferred into place in these eyes where I've disrupted the epithelium. I like to leave the donor lenticule on the stromal base to protect it from loose epithelium. I use a pull-through technique in cases like this to help ensure correct positioning because the view-in is somewhat inadequate. Proline is placed on in a double-arm fashion in the edge of the donor graft. The incision's open to 4.5 millimeters. The double-arm sutures are then passed through the anterior chamber, which is being maintained by the anterior chamber maintainer. important that the spacing of the sutures through the recipient cornea be at least as big as the space that they were placed in the donor. If it's less than that, folding of the graft will occur. If it's somewhat larger than that, that generally works out fine, as it will pull and stretch the graft into position. If the suture is going to be left in place for a short period of time, like I sometimes do for an aphakic eye, then the spacing is even more critical. I like to mark the edge of the DSAEK graft, put some viscoelastic on it, and then using the Pollock forceps and .12s, I strip the anterior portion of the graft off of it, and then with a tying forceps we'll pull the suture nasally and insert the graft, guiding it with the Pollock forceps. And it usually opens up nicely like it did there. I close the temporal incision. Align the OCT device so that I can see the recipient cornea and the donor graft. Right now we're seeing bits of the iris. Now the donor graft is coming into view. The focus can be done by an assistant, but also done at the microscope foot pedal, which is very nice. You can now see the separation of the recipient and donor grafts. And air will be instilled. First, I inadvertently place some in the interface, which will be removed. Now a bubble is placed under the graft and immediately positions it onto the recipient graft. And with the OCT we can verify that it is in place, which can sometimes be difficult in an eye with previous corneal surgery. Following this, the graft is, the corneal edge is sutured. And then a large air bubble is placed. I check people 30 minutes after surgery, and we'll decompress the anterior chamber if necessary. This patient has an inferior surgical PI present.